thank you very much, Mats, for having me. That was really important. As you all know, it's really important to involve patients' voice, opinion, perspective, because if we do not plan stuff in the direction of the real needs of patients, we just waste time and resources. So this is really a coincidence. I loved Anna's presentation. She talked about many topics that we are already involved in, but maybe later I can explain the one project with reprogramming cells to stem cells and then to breast organoids. I will talk about this later. And it's really also the role, besides the title you gave my presentation, there is down there the role of patient organizations in translational cancer research. I could not agree more. I mean, there is no, that doesn't make sense if the basic investigation and you cure animals does not go further and start curing people. This is just wasting, once again, resources. Why don't you do it the other way around and you start to talk to patients in the first place, ask them, what do you need? And then you can design together your research project, and then you can be sure that those results will be communicated to the patient community, and the patient community will be very inspired to get those new therapies through in the regulatory bodies. So I just want to bring a little bit real world inside this conference, because we are talking about investigation, science, it's very abstract, but there are people involved in that work that you are doing. And I just tell you very quickly the story of our patient organization. A typical story. It was when I was working as a nurse back in 2008. I took care of a 27-year-old pregnant woman that underwent a radical mastectomy after doctors had diagnosed her with advanced triple-negative breast cancer. So while I was listening to the baby's heartbeat and looked at this mutilated young, soon mother of 2 daughters, I thought, what happened here? Why could she advance that much with her disease and nobody noticed anything? So I followed up her doctor appointments, and I understood there was a strong family history of early breast cancer on her paternal side. So 2 paternal aunts died of breast cancer in their early 40s. And that was the time when I woke up for my own family history. Even being a nurse, at my time, they didn't know about BRCA gene mutations, but I had no idea that my paternal aunts and my grandmother that all had died from breast and ovarian cancer could influence in some way my own risk for breast cancer. Additionally, I had my mother that had a premenopausal breast cancer at 44. So first I called my paternal aunt, the only survivor at the time of ovarian cancer. And I told her, did you know we have a mutation in the family with a high risk for cancer? And she said, yeah, we know about this since then and then. And I asked her, why didn't you tell me? I mean, I could have been diagnosed in between. And she told me, yeah, you know, communication is not that easy, because in fact, everybody had died from cancer in our family. So remaining family members wouldn't like to speak anymore about cancer. So they just gave up on communicating the mutation in the family. So I found out, I felt grateful because I caught the mutation before cancer could catch me. I'm a mother of 2 daughters. And when those patients that woke me up for my own family history, died 2 years later from metastatic triple-negative breast cancer. I promised her that this wouldn't happen again to the next generation, speaking of our daughters, my 2 daughters, her 2 daughters. And so we founded this patient organization, Evita, to improve quality of life of families affected by hereditary cancer syndromes and saving more and more lives. Because in fact, we have 2 situations. We have the healthy gene carriers, so they have this sword hanging over their head, and they do not really, they are not sick, they cannot go to a patient organization. So that was the lack for our patient organization. We support also the healthy gene carriers. And then unfortunately, we have the sick gene carriers that would be avoidable. And it's really sad that mainly we come to the conclusion that there is a mutation in the family when somebody gets sick. So what I'm talking about is this is a real situation of hereditary breast and ovarian cancer. Evita supports all the hereditary cancer syndromes, but we just it's just better to explain it on this example because it's very clear that this rare disease is not rare at all, and it's killing parents. I mean, breast cancer assumed the very sad first place of the most frequent cancer in the world. So if 10% of the most frequent cancer in the world is hereditary, I mean, we are just talking about huge numbers. So after we founded Evita, we studied all the time with all involved stakeholders, what is state of art and what are we missing. So we identified a lot of really urgent unmet needs in hereditary cancer. It's located in multiple organ systems. So we often have the situation that the breast and ovarian cancer gene, BRCA breast cancer gene, is only related to the woman and the breast cancer, but that's wrong because it raises the risk for prostate cancer in men, for male breast cancer that most men don't know it even exists, pancreatic cancer, melanoma, and so on. So this name is leading to some confusions. We still have doctors that tell women that have a family history, don't worry about that. Just leave it alone. You already had cancer. We hear that a lot. I mean, the young woman has breast cancer. Having had breast cancer does not justify not to do the genetic testing because there are other organs and other family members at high risk. So also hereditary cancer represents 10% of the most frequent cancer, okay? So colorectal, prostate, breast cancer, 5 to 10% hereditary. Then some of the most lethal cancers also have a hereditary percentage. We are talking about pancreatic, ovarian, stomach, and melanoma, besides others. And not to forget, 10% of childhood cancer are hereditary. So a statement from our coordinator at the European Reference Network, GenTourist, for genetic tumor risk syndromes, Nicolene Nogabrugge, is at present only 20 to 30% of people with genetic tumor risk syndromes have been diagnosed. That means they are up to 80% with a sword over their head. They do not have an idea about it. It could even run in your family. So we need to improve the identification of gene carriers and update the literature. The identification of gene carriers misses up to 50% due to the family history that is not very evident. So my personal case, once again, is all the paternal aunts. I had a lot of aunts and my paternal grandmother, they all died of breast and ovarian cancer. So even somebody blind would have been boxed in the face, this must be hereditary. On my maternal side, my mother did not have any siblings. There was no family history, but she had a triple negative breast cancer at 44. So when she got 30 years later, her second contralateral multifocal triple negative breast cancer, I called her doctors in Germany and I said, you need to test my mother because we have identified a paternal mutation that I carry. My brother, father of 4 daughters, was negative for the paternal mutation. Please check if there is also a maternal mutation. There are 4 nieces in risk. And yeah, in fact, my mother also carried a BRCA1 gene mutation. This is very rare, 2 parents with a BRCA1 gene mutation. And then it made so many lights in my head because my mother always commented with me her complicated menstruation. Sometimes she didn't have her period. Sometimes it came all in once after months. She had miscarriages because the embryo inherited the two mutated copies of the BRCA1 gene but yeah, many lights came up. So then we have the other problem. Hereditary cancer generally strikes at an early age during the peak of the patient's productivity and even during childbearing years. It is therefore also the most expensive cancer. I mean, it's not difficult to understand if you have the 27-year-old soon mother of 2 little daughters diagnosed with a metastatic disease, chronically ill, not producing anymore and dying decades before it's supposed to. The Dallies and Yallies, they just jump up into the universe. So whenever they tell me hereditary cancer, not really important, very rare. Not so rare, very expensive. This is an argument for decision makers and payers because, of course, we are much more preoccupied with the health and quality of life of our gene carriers. But we need to do this calculation for our decision makers so they understand they need to allocate more budget to detect hereditary cancer earlier because it's our biggest failure in cancer prevention. We cannot diagnose a genetic mutation in a family only because somebody got sick. And then not mostly, but it's not rare that they have already an advanced diagnosis due to young age. Not the person itself, nor the healthcare provider gives the attention to the first symptoms because they just think she's too young to have a breast cancer. So if they are unaware of their genetic predisposition, the cancer signs may be disregarded. There it is. So with adequate measures, hereditary cancer has the potential to be one of the most avoidable and early detected cancer. Identified mutation carriers can choose to undergo early and frequent screening, as well as the preventive surgery. So when it made the big light was in 2017, when I went to an international experience exchange for patient organization. Those are many people in the picture. Where is Wally? I know where she is. Just entertain yourself in between. So I heard a lot about big data here, big data there. And then it made the light. What? Big data? We do not have small data with hereditary cancer. There are no data. We have no data on hereditary cancer. So if we do not have data, we will not learn, we will not develop anything. So on my journey to look around what is going on regarding data, registries, databases, networking, around the subject of hereditary cancer. Then I fortunately found the network, the European Reference Network for Rare and Complex Diseases. Therefore, I say always hereditary is a complex disease. It's not rare, it's a complex disease. And here they are already working, sharing and storing data on European level. This is very important. But when it came, so creating data on European level to increase significantly investigation and development, saving lives, improving quality of life and care, avoiding waste, subdiagnosis and overtreatment, promoting equity and saving money for the public healthcare system. Sustainability, value in healthcare. But when I came down to the national level in Portugal, there is this fact, we have a Portuguese founder mutation in the BRCA2 gene, and that gives us the highest incidence of BRCA2 mutations in Europe. So this is really a bullet point where we need to investigate what is going on with this Portuguese founder mutation. And this actually is happening. First of all, we could bring in 2015 Stephen Nayrod to our BRCA International Network Congress in Lisbon, and patient organization, this name of the huge investigator Stephen Nayrod. So all the interested scientists from Portugal came to our conference, and they got out of this conference with the compromise to start a network and to investigate, starting with the Portuguese founder mutation. This is happening right now, and besides other bullets, we also investigate when cancer starts in a gene carrier of this Portuguese founder mutation. For that, we took skin biopsy, not we, it's Maria do Carmo Fonseca from the Institute of Molecular Medicine. She took skin biopsy from our voluntary gene carrier, and they reprogram it now into stem cells, and then they will have breast organoids. Then they will be aggressive to the breast organoid, and they will understand when does cancer start in those gene carriers and why. This will be really innovative. So our recent National Cancer Registry, it's a fusion of 3 regional registries. Okay, so a small country like Portugal started to have 3 different registries. Don't ask me why, but it was just like that. Now, they put it all together in one national cancer registry, does not discriminate hereditary from sporadic cancer. There are no data available, no numbers, no arguments for payers and decision makers. What's the problem? The storing of genetic information. That is what they told me. So on May 25, GDPR entered into force in EU and consequently became applicable in Portugal. Additional data protection obligations are included in certain sector-specific laws, such as data protection on genetic and health information. So this is the big obstacle why our National Cancer Registry does not want to store something about genetic information. Again, if we do not have data, we won't gain knowledge and we will not develop anymore. So there we decided to do it down top, patient-generated data. We are in the way of constructing Evita platform. We need to save more lives. It was already 1 year ago, before the pandemic began, we had a solution to support gene carriers during pandemic time and lockdowns. because as you can imagine, gene carriers are sitting at home, the healthy gene carriers are sitting at home waiting to get cancer, but unfortunately nobody is going to see them because the non-urgent activities are suspended right now in the national healthcare system. So this platform is 100% patient-centered. Mutation carriers, doctors, investigation, all the stakeholders will be very happy with that platform. They will have different access to the platform. Of course, all generated data will be introduced and administered by the gene carriers autonomously and independently. The information will be registered in a structured way and processed using artificial intelligence. We talked already about that. So just very quickly, because the time is running, of course, for carriers, I mean, you can do genetic counseling by a video conference, no problem. You don't need to touch or to smell the patient. You just ask your questionnaire and you go to your risk calculation tool and it's done. And you know if the patient needs to give a blood or a saliva sample to do genetic testing. That would be really a huge relief for our system if we could accelerate this kind of process. Because once again, I know there's never enough money, and prevention is also a stepson of health always. But right now, even in post-pandemic times, I mean, not still in pandemic, but right now we already know we will have a tsunami of late-stage diagnosis in cancer. We cannot continue to generate more and more sick people. We need to hit on prevention, avoid disease. Evita, avoid, that's the Portuguese word. So please, prevention is super important, even more if we are talking about parents of young children or young adults that won't be parents anymore because they are late stage diagnosed. So we see this really very important thing. And this is one of the huge values we can create, alleviating the system in this kind of consultation. Of course, the artificial intelligence will give the personalized information. The Lynch carrier won't receive information about BRCA mutations. There will be moderated chat, teleconsulting. There will be alerts for clinical trials. It's really a very huge lack of functionalities, and everybody will benefit. The carrier can ask the doctor, allow his doctor to upload all the clinical process. The doctor can know in the actual appointment how his patient was during this time from the last to the actual appointment. We have also a huge value for investigation because once again, we create these data that are not existing right now. There are no patient-generated data on hereditary cancer, and we will start them, and we plan to widen it up to other European countries or maybe international, but that is only in a later stage. We just start here in Portugal. Now during the presidency, I hope we have our kickoff. Going back to the initial question, what would patients and patient organizations need regarding the regulation of genomic research? So you see here a photo, a picture of the Portuguese delegation of the EUPATI, European Patients Academy in Therapeutic Innovation of the EUPATI course in 2018, I think. Patients involved, she's holding up. Of course, we would like to have a word. I mean, nothing about us without us. It's so obvious. And please avoid overprotection from the regulator side. I mean, we know what we want and we know what we need. So who owns the data? It's the generator, it's the person. some people think they are the king of the town because they have a database, but the real owners are the persons. So we need to open up, and the people willing to share their data by informed consent sign, and they're encrypted also. I mean, open up to investigation, to research. We need innovation. We need structured education for both healthcare providers and citizens. The people need to understand why one cannot do the same therapy than the other. They need to understand we need to go more down on molecular basis. Breast cancer is not breast cancer. It's many, many things in individuals that have different interactions and so on. We need structured education for healthcare providers. We cannot have a doctor saying to a breast cancer survivor, no, why do you want to know about genetic mutation? You had already breast cancer. Not possible. Then I heard this term the other day, privacy by design. I thought that was a nice term. It means by origin the privacy is already integrated in the construction of the tool, but I think it means much more, and that is maybe a thing we should discuss further. And then there is our right to research and development. I mean, only because we are genetic or rare, or whatever they call us, we still have a right to research and development. And now I leave you with this ultimate photograph of this bald, sick mother you saw before. You see the 3 generations, the typical story, a happy end. The mother that was diagnosed with breast cancer and found out about the mutation in the family, made that her positive daughter advanced with preventive surgeries and avoided cancer that way. And then she had pre-implantation genetic testing for her little daughter that is now mutation free, and the mutation is finished for this family forever. Thank you a lot.